Good morning, everyone, and welcome to the Health Committee meeting for the County of Renfrew. It is Tuesday, September 10th, 2024. It is 9:30 a.m. I'm calling the meeting to order. As we gather this morning, I wish to acknowledge on behalf of committee and our community that we meet on traditional territory of the Omama-Winini Algonquin people. We thank the Omama-Winini people and express our respect and support for their rich history. We are extremely grateful for their many and continuing displays of friendship. We thank as well all the generations of Indigenous peoples who've been careful stewards of these lands for millennia. I'm wondering, Ms. Van Starkenburg, has the roll been called?
Yes, thank you, Chair, and we have quorum.
Thank you very much. I would invite now disclosure of pecuniary interest, and if any, the general nature thereof, please. I see none. I'd now seek a motion for the adoption of the open minutes of August 14th, 2024 committee meeting. Councillor Weir, seconded by Councillor Murphy. Any errors or omissions? I see none. All in favor? That is carried. I'd now seek an adoption for a motion for the adoption of the closed minutes of the meeting held August 14th, 2024. Councillor Lafreniere, seconded by Councillor Weir once again. Committee, any errors or omissions? I see none. All in favor? That is carried. Thank you once again. With that, very pleased to have a delegation here this morning. Very timely update in our community. And I would call upon Councillor Nicholson, who also serves as the Vice Chair for the Board of Health, to please introduce our guest this morning.
Thank you, Chair. And an easy introduction. And I have to mention I'm not the only member of the Board of Health on our committee today. We have Councillor Purcell, Councillor Murphy, and I'm quickly looking, and of course, our warden, Peter Emo. So he's a face that we're very familiar with and one that we've come to rely on very much, especially as we go through what we're facing now with opioid crisis, mental health crises, essentially some very large public health problems. So I'd like to just welcome Dr. Jason Morgan-Stern to the podium today. I practiced. And as you've mentioned, he's our Medical Officer of Health for Renfrew and District, which not only includes Renfrew County, but Pembroke and South Algonquin. So, Dr. Morgan-Stern, floor is yours. Thank you very much for taking the time today.
Thanks so much for the kind introduction, and thank you for inviting me to come and speak to you today about the Renfrew County and District Drug Strategy. Just to start out, I wanted to provide a little bit of context, which I don't think will be new to many of you, but unfortunately what we're seeing across Renfrew County and District, across Canada, and really across North America is a rapid escalation in drug-related harms and drug-related deaths like overdoses. In particular, where we're seeing a lot of the increase in harms is related to opioids, so things like fentanyl. And unfortunately, many of the people that are most impacted by this crisis are young or middle-aged, and so when an overdose death occurs, there are many, many years of life lost, which just adds to the tragedy. And in terms of the direct causes of the crisis that we're in, it's complex, but one major factor is that the increasingly contaminated street drug supply, increasingly toxic and unpredictable, that's really playing a role. Locally, last year we had 41 suspect drug-related deaths. This was about 3 times the rate of deaths that we were seeing before the pandemic. Also, the Algonquins of Pikwakanagan First Nation, as you know, declared a state of emergency related to the opioid crisis. So it's having a really severe impact on our community. I just, for a little bit more, I have a graph here showing the suspect drug toxicity deaths in Renfrew County and District. At the top of the figure, you can see each of the 4 quarters for 2023 and the number of deaths that occurred. And for the 2023 total, as I mentioned, 41. For 2024 as well, so far, lower down in the figure, I have the deaths there portrayed by quarter, and so far this year, there have been 21 deaths related to drugs. When comparing to the same time last year, this is fewer, but still really what you can see is that the impact on individuals, families, and communities is staggering locally. And it's important to remember that deaths are just part of the picture, so there's also many more emergency department visits, healthcare provider consults, EMS calls, and then times when there may be an overdose that's treated with naloxone and there's never an additional call for help. So for some of those indicators, to provide a little bit more in-depth information, we've started a substance use harms dashboard that you can access on our website that gives a picture of a few more of those indicators. Overall, given the rising impact of substance use harms in our community, we came together with partners to initiate the Renfrew County and District Drug Strategy. And up on the screen here, I have the vision that's been articulated by the steering committee. So Renfrew County and District is a community that is compassionate and inclusive, that works collaboratively to reduce and eliminate the harms associated with substance use, which will improve the safety, health, and well-being of all individuals. The steering committee has also decided on a mission statement, which is to develop, implement, and evaluate an evidence-based comprehensive drug strategy to reduce substance use harm using a person-centered, non-stigmatizing, and equity-focused approach based on the pillars of prevention, harm reduction, treatment, and community safety. So I'll get a bit more into exactly what that means shortly, but first I think it's important to acknowledge all the great work and collaboration that's already happened and is being done. And just to name a few things, last year we saw the collaboration on the warming center in Pembroke, which was much needed and just showed solidarity with the most vulnerable in the community to ensure that they were protected throughout the cold months of the year. The MESA initiative by the County of Renfrew has also been a phenomenal asset to the community, in particular for those who are underhoused, and ensuring that they have greater access to medical care, addictions treatment, harm reduction, medical, social, and other wraparound supports. And then also I think it's important to mention that there's an extraordinary amount of work every day by our outpatient, inpatient, and emergency treatment providers who are responding directly to mental illness, substance use disorders, and overdoses throughout Renfrew County and District every day. So in this context, the goal of the Renfrew County and District Drug Strategy is really just to facilitate an integrated, comprehensive approach to reduce drug-related harms locally by working together on existing initiatives as effectively as possible, and jointly deciding on new initiatives that are needed. So just putting up here, I won't go through all of them, but I wanted to give you an idea of the organizations that are represented on the steering committee. It gives an idea of the breadth and the expertise at the table. At this time, myself and Jema Watt, who's the strategic implementation lead for the Ottawa Valley Ontario Health Team, are the co-chairs of the steering committee. We're also very grateful to have Mayor Donahue and Mayor Giardini joining us at the steering committee. And there's also many other representatives of County of Renfrew agencies, and additionally we have experts, service providers, and people with lived experience at the table. So the engagement, support, and leadership from everyone is very much appreciated. So up here, I just wanted to show you that we're using a well-established model for the development of community drug strategies that relies on 4 pillars. So prevention, treatment, harm reduction, and community safety. There's a network of drug strategies across Ontario, actually, that uses this approach, and it's made a lot of headway in multiple other jurisdictions in North America, Europe, and other parts of the world. Related to each of these pillars, we have established a working group, and 3 out of 4 of the working groups so far have made their initial reports to the steering committee. And the way that we're organizing that is that they're initially providing a situational assessment about what we have right now in Renfrew County and District, and then making some preliminary recommendations to the group. So I'll start by talking about, I'll go through and briefly just discuss a little the work of each working group. And I'll start off with the prevention working group. So you can see some of the organizations that are partaking in that on this slide. Some of those are Phoenix Center, McKay Manor, Addiction Treatment Services, as well as the Ottawa Valley, Ontario Health Team, Mental Health and Substance Use Health Network, and Renfrew County Child and Youth Services, just to name a few. And what they're largely focused on is protective and risk factors for substance use and placing an emphasis early in life on children and youth. Just for some background, some of the important factors that can contribute to the risk of substance use disorders are availability of housing, income, trauma, adverse childhood experiences, and mental illness. So those are a lot of the focus. And so far, we've learned a great deal about much of the good work already being done in this area, including a number of joint initiatives involving addiction treatment services, school boards, Phoenix Center, and the Algonquins of Pikwakanagan First Nation that are providing mental health and addiction services in schools. There's also been the recent establishment of the Youth Wellness Hub in Renfrew County, which is a major asset to the community and our youth. So up here are some of the preliminary recommendations that the prevention working group has brought to the steering committee. These will be further discussed, refined, and elaborated on, but I just wanted to give you an idea, and I'll mention just a couple of them. So number 2 is to support providers to deliver care together with improved communication, pathways, and case coordination. And an example of this is I mentioned that there's work being done in the schools. So Addiction Treatment Services and Phoenix Center are working together to provide integrated care in a new initiative, just to give you one example. Another recommendation on here is regarding early education, promotion, and prevention. And so one of the examples of current work going on there with the health unit is the Healthy Babies, Healthy Children program, which involves one of our public health nurses meeting with families at the hospital right after the birth of their child, and then if desired by the family, they can engage in home visiting to provide more ongoing support for healthy growth and development. However, there are additional interventions that could be considered. For example, the nursing family partnership, which has been shown in randomized controlled trials to result in improved outcomes, reduced risk of mental illness and substance use later in life. So again, that's one thing that we could look at. And then on this slide, I'll just mention the last one. So creating a unified system of care and filling gaps in service, including for severe mental illness, crisis, Indigenous children and youth, complex needs, and rural and housing needs. There's also been some discussion in talking about prevention and actually all of the different working groups about establishing a joint evaluation framework with indicators so that we can measure the effectiveness of the different programming on an ongoing basis. And as I said, the working group will continue to refine and elaborate on these recommendations for further discussion as we go ahead. So next I'll talk a little bit about the treatment working group. Some of the key members here are Addiction Treatment Services, McKay Manor, Pathways, the MESA team, and the Ottawa Valley, Ontario Health Team. And I just wanted to note that the treatment landscape for substance use disorders is very complex. There's many different parts to it. It's very individualized and really just tries to meet people where they're at to most effectively bring them through that treatment and recovery process, which is different for everyone. But some of the aspects that are included are acute medical detox beds, stabilization beds, residential treatment, and there's also outpatient treatment with different modalities, so medical therapy, as well as counseling, and there's many other aspects, but I just wanted to give you a bit of a sense of that. So here are some of the treatment preliminary recommendations. The first one on the page there is increasing and expanding our existing high-demand outpatient services that are currently exceeding service capacity. And so one example there is for addictions counseling services. Another recommendation is exploring the possibility of establishing medical detox beds here in Renfrew County. And then at the end of the slide, continuing to increase our short and long-term supportive housing, including availability and breadth of associated integrated services and specific services for people who use opioids. And then I'll just mention one here. So developing a communication strategy to ensure that our clients and providers are aware of the most up-to-date services, and including some recent improvements to reduce or remove barriers to existing services and care. All right. So I know I'm moving kind of quickly here, but I'll talk just a little bit about the harm reduction working group. So this is co-chaired by the Renfrew County District Health Unit as well as Addiction Treatment Services. There's members from multiple other agencies. For some background on harm reduction, this is an approach that acknowledges that not everyone is ready for decisive treatment, and it takes a pragmatic approach with the goal of really minimizing the harmful consequences of drug use. And two of the major factors there are reducing the spread of bloodborne illnesses that can often happen with contaminated drug equipment. So that would be things like HIV or hepatitis, as well as reducing drug-related deaths. And so some of the local work that's already occurring in this area includes distribution of naloxone, which is a life-saving medication that is safe and reverses opioids like fentanyl, so that breathing can be restored and you can avert an overdose. There's also communications, for example, the opioid alerts that are put out when we're seeing an increase in overdose rates. And then distributing and collecting clean drug use equipment to prevent the spread of those bloodborne illnesses spreading. So here are just some images of some of the preliminary recommendations that have been discussed. So one of them is about the promotion of a consistent, what's called a spotting services app or calling services for those that are using drugs alone. So the recommendation is always, from a harm reduction lens, to avoid using drugs alone whenever possible because it's very dangerous. However, there are these services that can provide a way of remote monitoring, and then a plan should someone become unresponsive so that emergency medical services can be engaged. The next is to continue to expand access through the Ontario Naloxone program by onboarding additional partners. And the third is adding drug checking availability, and this was actually already implemented in July by the health unit, so that testing strips are available so people can see if some common contaminants, for example, xylazine or benzodiazepines, are in the drug that they're using, and that can result in behavior change and reduce the risk of overdoses. And then lastly is implementing a centralized alert system regarding the overdose alerts, not just with media releases and social media and the like, but also having a text message list so that we can more directly get that to the people who need it most. And the group also discussed continuing to monitor other opportunities, including overdose prevention sites. However, in light of recent provincial announcements, for example, the removal of the ability to apply for new supervised consumption sites, there are currently fewer opportunity to deploy those types of evidence-based interventions. But we will continue to monitor the situation. And the last working group that I wanted to talk about is the Community Safety Working Group. They recently had their first meeting, and they'll be providing their first report to the steering committee at the end of this month. There is a lot of natural alignment with municipalities' community safety and well-being plans that have been developed, so an update on those plans is going to be provided at the steering committee at the September meeting, and also the initial report on the situational assessment and preliminary recommendations from that community safety group. It is somewhat focused on Pembroke at this time due to the pressures in that community, but we'll be looking to expand further countywide representation as the group becomes more established. Some of the preliminary priorities that have been identified are around enforcement, social order, sharps disposal, communications, and complaint or reporting mechanism. And then I wanted to talk a bit, we also established a communications team. So it's, the goal with this group is a few different strategies. So the first is to increase awareness including informing our community collaborators and partners about the drug strategy and its goals. The next objective of the group is to disseminate information, so providing timely updates on the progress of the strategy, as well as reducing stigma by sharing evidence-based information and personal stories. Fostering support for the drug strategy from champions and leaders and key organizations, and then also enhancing engagement and encouraging active participation from the public and our collaborators. And there will be a media release that this group has worked on coming out this week, just to update the community that the strategy is being worked on and who's at the table, that sort of thing. I also just wanted to touch on a couple emerging opportunities. So the first is the Substance Use and Addictions Program, which is a funding opportunity that this community applied to collaboratively through Health Canada and was successful in receiving the funding. So that was announced a bit earlier this year. So there was a group meeting together on how best to deploy this. The proposal was around a mobile substance use service, and so the team is working closely with the MESA team to implement the program and essentially complement those services and expand what that team is able to do. There's also, with the announcement a couple weeks ago from the provincial government about the supervised consumption sites, they furthermore announced the opportunity to apply for what they're calling homelessness and addiction recovery treatment hubs. So there are 10 of these spots that will be available across the province to provide a sort of, the idea is a one-stop hub with different treatment services for addictions and mental health, as well as a component in there for supportive housing that needs to be addressed. So that's an exciting new opportunity, and the drug strategy members and others throughout the community are working collaboratively on putting together a strong application for Renfrew County and District for that opportunity. And in both of these cases, they'll relate heavily back to those treatment preliminary recommendations that I talked about. And hopefully, as these move forward, we'll be able to use these opportunities to directly address some of those. And I just wanted to briefly outline the next steps. So there's, at the next steering committee meeting, the Community Safety Working Group will be coming, providing their initial report and preliminary recommendations. Then collectively, we'll be refining and elaborating on the recommendations provided by each of the working groups. There will be community engagement, and then the development of final recommendations and a report, followed by strategy development, implementation, and ongoing evaluation. So hoping for that to be underway in early 2025. And thanks everyone for the chance to present to you, and happy to answer any questions.
Thank you very much, Dr. Morgenstern. I certainly appreciate that this was an abridged presentation, given the scope and scale of the scourge of opioids in our community. But I do thank you for being able to provide a very comprehensive overview in a very short amount of time. With that, though, we will provide some opportunity for questions or comments from committee. I'm going to begin with Councillor Murphy, followed by Councillor Weir.
Thank you, Chair, and thank you, Jason. One of the things that I've kind of been known for over the past few years is me railing against the community and safety well-being plans. I don't know how they help the OPP or, quite frankly, our paramedic service. I feel that it's a duplication of things that we've already done, and in fact, what the health unit is doing. I'm just wondering, are you hearing any feedback from the community or our OPP as to how these plans are working?
Dr. Morgenstern, please.
Thanks. At this time, actually, we haven't discussed it in depth. I'm thinking that at the next steering committee meeting, there will be more opportunity for discussion, but your comments are well taken, and thanks for providing that.
A follow-up, Councillor Murphy.
If you don't mind, Chair, I'm a COPS kid, and when these came into play, my 43-year veteran of the Toronto Police laughed himself off a bar stool, because there's no way when an officer is going out to a call They're not grabbing a plan off a shelf. This means that every officer has to know exactly what's in the plan. We could potentially have 18, 19 different plans within the county. I know that we don't. Some of us have amalgamated our plan, but that doesn't matter. Even if we have 8 plans, it's too many when we've now amalgamated Killaloe Detachment with Upper Ottawa Valley. It's just too much for each officer. So therein lies my concern and the reinvention of the wheel. Thanks.
Thank you. Councillor Weir, please.
Thank you, through you, Chair. I'm just wondering, like I have an naloxone, I'm pronouncing that wrong, kit in my car. And I'm just wondering, do we have any tracking methods of when that's used? I mean, if paramedics show up and they use it, but if a private citizen uses it, is there anything incumbent upon the person using it to contact medical staff to say, this has been used, I don't know the person's name, I don't know how to track it, but do we have any feedback on how often it is being used by private citizens?
Doctor.
Thanks for the question. With private citizens, there is, the recommendation is that if naloxone is used, it's a medical emergency or suspecting an overdose, and we always recommend that 911 be called as well at the same time, because what we're finding is that with the degree of toxicity of the drug supply, often you have to use more than 1 dose of naloxone. So we need that additional assistance. And the other factor is that sometimes it's not just opioids that respond to naloxone. There can be other things like I mentioned, xylazine or benzodiazepines that don't respond to the naloxone. And so you need more comprehensive medical care to address those aspects. So that would be what I'd first say, so that we would hope that everyone, but we know that doesn't happen. And so, in a private setting, if somebody's using a naloxone, there's no automatic way that we would know about it. When our service providers are using it, part of the way that we conduct the overdose surveillance and alert system is that all of the partner agencies, we have a portal that they're regularly reporting into about overdoses that they've responded to and when naloxone was administered and how many times. So that type of data we do collect, and we monitor that. And as I mentioned, we are seeing increased instances of times when there's many doses of naloxone having to be administered before the overdose is reversed.
Thank you. Just as an addition to that, I just pulled it up. I'd shared it because I couldn't remember. Science Up First. There was a link some time ago that I actually shared, and it goes over a lot of opioid overdose response, myth versus fact. And in fact, it picks up on what you were saying, Doctor, and in fact on the question. And that is part of what they are recommending as and encouraging citizens to respond. And in doing so, that there is more than just the administration of the naloxone, that it is part and parcel of ensuring that person is not left to their own devices. So thank you very much for that. Councillor Nicholson, please.
Thanks, Chair. One comment, one question. So the first one, and I've kind of echoed this before, but when I looked at the preliminary recommendations that were in the presentation, the first question that came to mind was, who's going to act on those recommendations? And I completely acknowledge that the committee, the organization that you're working with, co-leading, doesn't have the power to task other agencies, but I would be very curious as to what the recommended lead agency might be in the opinion of the group, just to give context as to who might be best to lead a specific recommendation. Mm-hmm. The second point, the question has to do with arm prior, and I'm just curious, arm prior being within the health district but outside of the OHT, has that posed any problems in terms of coordination or ensuring that they receive the same kind of supports that we're looking at for other organizations?
Dr. Morgenstern, and in fact, I think the first one may have been a question as well with respect to the lead agencies, if you wish to address that as well.
Thanks. Yeah, so I'll start with the first question. So really, we are relying on the goodwill of the organizations and their leadership. In being part of the steering committee, it doesn't have formal authority, but the idea is to produce recommendations collaboratively that each of the agencies, depending on the recommendation, can implement in their own way. I mean, it's an extraordinarily complex issue, and you can see that just in the different number of working groups, each of which will have multiple recommendations. So for each of those even individual recommendations, there could be multiple agencies. However, practically speaking, I agree with the point that it's important to have leads. That's in part why we're trying to, organize the work in the steering committee and the different working groups, so that can kind of divvy up the work. However, when we're, for example, doing funding applications to the Health Canada or to the Ministry of Health, those have to have lead organizations formally embedded, and so that, for example, if we were successful on the heart hubs, there would be lead organizations associated with that would be carrying it out, again, with multiple partners contributing, which is always the case, but so I don't know if that helps, but it's a complex situation. The other thing is regarding armed prior. Thanks for bringing that up. Yeah, we want to make sure that we're being as inclusive as possible. Sitting at the table, the Ottawa West Four Rivers Ontario Health Team does have a seat as well. So we are talking with them. So they're the one that encompasses McNabb, Braeside, and armed prior. So we want to be as inclusive as we can. But again, as we go, I think that we'll continue to refine and ensure that we're meeting every community with the needs that they have. So, and sorry, could I just do one follow up on the naloxone question, if Mr. Chair?
Oh, please do. Yeah.
I should have mentioned that while we don't know with naloxone whether it's actually being used in every case, we do keep track of the distribution through the pharmacy channels and through the health unit and through all the other partners. Last I heard this year, that was well over 7,000 kits that had been distributed. So that number we do keep track of, and that's been steadily rising year over year. So.
Warden Emo, please.
Thank you. And thank you very much for being here today. One comment and a question. I think if I recall correctly, whenever a citizen assists somebody else, they shouldn't worry, because I think we watch too much American TV. They shouldn't worry too much about liability because of the Good Samaritan Act. If you could elaborate a bit on that. And then the next thing is, this is a little off script, but could you talk about the conference you attended this weekend and just some of the themes that I think are central to what we're trying to do here?
Great. Yeah. Thanks for the first comment. So that's true. The Good Samaritan Act in Canada does provide protection for any bystander individual who's trying to provide support to somebody who's having an overdose, and that includes in terms of medical liability, but also in terms of personal possession, should they also be somebody who's using drugs. So, and that is really there to ensure that there's, minimize any fear about legal consequences, and we strongly encourage anyone who's suspecting an overdose to respond as quickly as possible. And thanks for bringing up the summit this weekend, or it was this weekend and end of last week. So I did attend a conference that was held in Timmins, and this was a sort of national gathering, particularly with a focus on smaller communities, towns, and rural areas, about the substance use crisis and how we can adapt our response. And so there was a lot of great presentations from experts and a lot of good tabletop discussions to start to try to develop what they're referring to as a playbook for how we can address this in smaller communities, because up until now, much of the evidence base and response has been focused in large urban centers, and so wanting to adapt that as well as possible. And so I understand they'll be taking that feedback and then coming back to us with a sort of proposed playbook, as well as resources to help us in our response. And I think there's a number of aspects that were discussed. I think it's one thing that stood out to me was a message of hope, and that while the situation is dire, there have been other countries or places that have successfully addressed other drug crises. And one example brought up was Switzerland, using a multifold sort of drug strategy approach with harm reduction, treatment, and all the other elements. and able to significantly reduce the overdoses they were seeing from other types of opioids in the 90s, and how they had, it took a number of years, but they were able to successfully address that. And so I think there was that message. There was also a lot of discussion about how can we make treatment services more efficient and accessible, that I took away. So for example, if somebody's going to the emergency department, doing everything we can to make sure that they're directed, if they're ready, to the, appropriate treatment resources, having virtual walk-in options, lots of different ideas like that I think still need to process and take back and discuss with our partners. But it was great in terms of the message of hope, the idea generation, and also connections with many others across not just Ontario but Canada. There were people from Alberta, PEI, Nunavut there, and how we're all kind of facing a similar terrible situation, and how we can work together to address it. So.
Thank you. Anything further? I just had a couple of comments. One, all of these pillars need to move forward, and I think that it is outstanding that it's recognized, the community safety pillar, because certainly the people most affected by opioids are those with substance use issues. But largely there are sectors of the community that are having impact from that as well. And we must be cognizant as well of that part of our community and make sure that we are moving in lockstep forward in recognizing their challenges and concerns as well. Two other elements that I wanted to bring forward. One, it was with respect to, this is on page 6, I think it's the bottom slide. Increase and expand existing high-demand outpatient services. At the last meeting in August, it was Kim McLeod from Addiction Treatment Services, just in some of the slideshow that she had presented. It appears that they're receiving about 25% of the funding, or funding for 25% of their clientele. I think what she had advised was there's about 400 individuals, clients that they are receiving funding for, but they're more on the order of almost 1,600, and it is through ad hoc, donated, etc., scratching where required, that is providing some funding from other outside agencies. So I think that really goes to show some of the gap. The only question I have is with respect to slide number 2, and that was the charting with the opioid-related deaths. And I'm given to believe that we're probably seeing there the impact of harm reduction as opposed to making inroads into substance use and the opioid addictions more generally. Very pleased nonetheless, but as harm reduction, it's not particularly making a dent in the overall problem that we're being challenged with. Is that accurate, or are we beginning to see some inroads, particularly maybe with respect to prevention? Are we seeing some inroads into reducing the prevalence?
Thanks. That's a great question. Unfortunately, it's very difficult to say for sure what is resulting in the lower number that we're seeing this year. It's important to keep in mind that given that we're a relatively small community and dealing with relatively small numbers compared to other parts of the province, there can be significant year-to-year variability that may not be consistent. So I don't want to get ahead of ourselves at all, but I think that it could be a number of factors. There have been a few different initiatives, some of which I mentioned. Even the warming center, may have helped direct people to services that they need. The Mesa initiative, again, may be connecting some of our most vulnerable in our community earlier on to care. So those could be already starting to show an impact. It could be both in terms of treatment and harm reduction, but there has been a significant ramping up of naloxone distribution to more organizations this year have continued to sign on, and so that could be a significant part of it. I think regardless, while harm reduction in some ways isn't solving the underlying problem, I think it's essential because we're just seeing so many deaths that anything that we can do to keep somebody alive long enough that they have a chance to seek treatment is amazing. So I think regardless of the exact cause, I'm happy to see that it's maybe reducing. But really important, I think, to keep in mind that harm reduction and treatment, they're not opposites or anything like that. They really should be working together, and we need both, and they both need more resources across locally as well as across the province so that we can better address the problem. So.
Absolutely, and much appreciate your answer. And I think that it's imperative that all four of those pillars be moving apace if we're going to make inroads into this. So, sorry, Mr. Kelly.
No, thank you, Chair. I thought it'd be appropriate to impart thanks from the county's perspective, of staff perspective, to Dr. Morgenstern, and of course his predecessor, the health unit, helped guide us obviously through the pandemic and help stand up VTAC, of course, in early days and work with us through there. We've acknowledged in this chamber, of course, the synergies we have and may have with the health unit moving forward, and I think speaks volumes that we're working together on things like MESA and the warming center, as the doctor has mentioned. And of note, and we seem to have quietly went through it today, but this afternoon, the Community Services Department is going to hear more about the Heart Hub and quite the departure from our regular lane, if you will, that the health unit and the county and our MESA partners have taken towards a solution on supportive housing and mental health and addiction moving forward. So this is in our world, this is quite a challenging and changing environment, and we're happy to be partners with the health unit moving forward.
Thank you very much, Mr. Kelly. And last word to the warden.
Thank you. And just to add to to what our CAO said, I have to reassure the chambers and the community that Dr. Morgenstern is a very forward-thinking person, and a lot of times organizations have the right person at the right time, and I think in this instance, the health unit has the right person at the right time, given your experiences outside of this community, in larger communities. And so it's very important to recognize, the transformation that we're going through. And I know we have a good partner with the health unit, and there is a number of synergies between our different function centers. I'm not sure how to explain it. We call them divisions sometimes, but I think with all the tasks that are completed by your nurses and your social workers, in conjunction with what's going on here and other partners, I think, as I say, I think the health unit is well positioned to be a good partner as we move forward. And I have a lot of trust in your abilities to help guide us. So thank you.
Hear, hear, Warden. Thank you. Once again, Dr. Morgenstern, enormous appreciation for you being here. I think that we probably should work to making this a standing, perhaps on a quarterly basis. I think there's an incredible value is returned in the proselytizing and the communication of what is going on in our community, but also what is being done to address the challenges in our community. So thank you once again.
Thanks, everyone. Really value our partnership and working together as well. So thanks a lot for the chance to be here.
With that committee, we will go back to the committee report. We are at item 8, Administration Department report. There was none at the time of mailing. Mr. Kelly, to catch you off guard, there continues to be no administration report.
Never off guard, almost ready. There is no administrative report today, sir.
Thank you. Thank you. I may have to separate you two. With that, then, I will go directly to Chief Nolan to take us through the Emergency Services Department report. Chief, if you please.
Yeah, thank you, Mr. Chair, and through you to members of committee. Within item number 1, we have a short presentation available, Mr. Chair, that I'd like to invite Matt Cruchet to the front of the council chambers.
Sure, and I think that that's probably best served by doing that right up front.
Thank you, Mr. Chair. So while Matt is making his way to the front, Matt is one of the lead commanders for our paramedic Sierra team here in the county. Matt comes with a very strong background in risk management, which is really the lens by which Sierra team and our other activities, including the MESA program, the VTAC program, and others, are undertaking, looking at our community and the needs of our community in a different way, and how do we optimize both the efficiency and the impact of the work that paramedics are doing to serve our population. So with that, Matt, I'll turn it over to you.
Thank you, Chief. And thank you for the opportunity to speak to you. I think that our staff really appreciates your interest in this, and it's going to be my pleasure to kind of enlighten you a little bit more about what we've been doing, because we've been pretty busy for the last little while. So Sierra Team is our special operations team at Renfrew County Paramedic Services. We have we're pretty busy as special operation teams go. In the last 3 years, we've done over 100 calls. We've done about 140 or so patient contacts where we've actually managed patients in these environments. And we are emerging as leaders in this area and within the paramedic service. And I'm just going to speak a little bit to that as we kind of go through this. So what I'd like to do is just go through the report. I believe you have in your package more of a document of our team profile. I'm just going to highlight the key points to the various pages of that as we go along here. Sierra Team expands the operational capacity of our service to areas where regular paramedic service operations get stretched beyond what would be considered a normal type of response. Our mandate is essentially threefold, and it's to bring care to the patient rather than bring the patient to care. So our job is to go to the patient and initiate high quality care in situ, which means in place. So we are there for the patient wherever they are. We make access and begin management for that patient. And then the third part of that mandate is to maintain continuity of care. So maintaining the medical care that's being provided through the course of that patient's journey to definitive care. And that is going to ensure the best possible outcome for the patient. So that's essentially our mandate to do that. We work regularly with many different partner agencies. Thank you, Tina. I'm not clicking it. We work with our surrounding fire departments and surrounding paramedic services. We work regularly with Ontario Parks. We work with the OPP, the Canadian Forces, especially 424 Squadron out of Trenton. They are the SARTEX. And we also are beginning to work more closely with 427 Squadron out of Garrison, Petawawa as well. We work with MNRF Aviation Services on a regular basis. We work with CNL. We work with Ontario's Medical Assistance team as well, which is called EMAP. So we have a lot of partnerships and ongoing relationships that are really key to our ability to provide the care we want to provide to patients. We work hard on interoperability and ensuring the most effective resources are utilized to provide the best care possible to our patients. So as an example, I was down in Trenton last week training with the SARTEX on a new rope access system that they're using. And we try our best to mirror our processes to what they do, because we end up working together so often that we want to be running the same systems. So today, and I apologize for my casual attire, but after this, I'm going out to do training on ropes with our team in Calabogie. So I'm on my way there. So, and we're going to introduce that system today. Like within a week later, we're on the same page again, and we're interoperable. So that's kind of how we try to approach this as much as possible. We've adopted standards that best meet the needs of our operation environment. And the ropes is a good example of that. We follow a mountain rescue approach to how we do rope access rather than we need to be able to carry everything we have with us on our backs into the bush to do what we need to do. And that's a little bit different than other systems where you show up in a truck and you have an unlimited amount of stuff you can use to deploy to fix that situation. So we really work hard on finding the best system to meet the needs of our deployments. We pick the programs pretty carefully to match the types of calls that we do, and in some cases we need to define our own framework and develop our own competency assessment for certain areas of what we function, and we've done that. team is staffed, thank you, 100% by paramedics. And that's actually a little bit unique. We have a fully autonomous operational mandate. Most other special operation paramedic teams are attached to another agency. So they would be attached, as an example, to the OPP's ERT team, or they'd be attached to a fire team, and they provide the medical function to that unit. But we are 100% paramedic. And the reason for that is because the reality of our area is that we have very few special operations teams of any kind that provide these specialized services. So we've stood up the capability to provide some of those missing pieces that exist in our community. We work it works really well to be independent so that we can pivot and respond to the needs in the community as they come up. And we've been doing that for the last, 7 or 8 years. We've kind of evolved to meet different needs as they come along. So that's been really important for us. We have a really rigorous selection process. We actually, we're undertaking an onboarding this fall. And to get the right types of paramedics on the team, we have a very kind of strict program of how we onboard people. And then we also maintain competency by doing annual assessments of physical fitness and also the ability to perform the various functions of the job. So it's a high operating paramedic team. We have 2 areas of capabilities primarily. One is remote access. Let me see if I can move that. There we are. So remote access is getting to people that are in difficult places to get to that typically we wouldn't be able to do with an ambulance. We have, our approach, our mandate is really to manage 2 patients for 24 hours in any environment that we may come across. And to do that, we have equipment that allows us to operate in the wilderness, on waterways, on slopes, in the trails, in the forestry areas, when we have floods. These are all areas that we train and are able to provide service to. Access and extrication options for us also include a lot of work with partner agencies. So our paramedics get on float planes and they fly into the bush. They get on helicopters and they are brought into the patient. They use a motorboat. We have a boat now, but we get on a boat and we use that as part of our deployment mechanisms. We're on UTVs, we're in canoes, we're on foot. So we will do whatever it takes essentially to get to where we need to go with the patient. The other mandate is, the other capability that we bring is a CBRNE hazmat capability. And with this, we are really laser focused on patient care here. So our role is not to manage the whole hazmat scene by any means, but it's to manage the patient or patients involved with that and the other responders that could also potentially be involved with that situation. So to do that, we've adopted the EMAT program, and all of our medics are trained to this, the specialist certification level of that program, which allows us to operate in a level C PPE environment. We run that program in a mobile deployment model, so we have the ability to set up a decontamination tent, essentially, that we can set up on site of an accident, as an example, to decontaminate people before they end up in our ambulances that contaminate the ambulance, and now the ambulance is out of service indefinitely. Or we can bring that same setup and put it in front of the hospital and help clean people as they come in and keep the hospital capability going. So that's one of the functions that we serve there. We also do high-risk infectious disease transport, so we have specialized equipment that allows us to move people that have high-risk disease, essentially, from point A to point B in a contained and isolated area. And we also provide subject matter expertise in this area to hospitals and other responding agencies as from the medical perspective that goes along with that. So those are our 2 big areas. We also have just added recently in the last year a marine unit, and this has been a really important addition to our capabilities. With with that water environment part of things. So we've had numerous responses over the last year since the Marine Unit became operational. The unit allows us to get a paramedic to the patient as quickly as possible, initiate treatment, and then transport that patient back while continuing that continuity of care. And the craft that we have has proven the concept for the type of space that we need to be able to operate in. Most boats are not conducive to patient management. They simply don't work. You have to have somebody flat. They have to be enough room around them that we can have a paramedic at the head and a paramedic at the side, and we can provide the advanced life support that we do. And that's really an important component of that. So the boat's configured to manage patients and to provide access, whether the patient be in the water or maybe perhaps on shore, that we can move them onto the boat and move them as we need to. And we've demonstrated multiple responses that the value this brings to patients in our community. So that's been a really important asset for us and the patients in the region. I'm going to wrap up shortly, but I just wanted to highlight for you some of the actual calls that we've been doing. I think it's the best way to kind of like tell the story, and it's kind of the Sierra team in action. So the images on this screen are all from calls we've done this year. These are images from actual missions. We've been involved in 27 incidents so far this year. We have a fall season coming up, which tends to be pretty busy for us as well. So overall, this is probably going to be a pretty active year for us. And I think perhaps one of the things, if you'll indulge me, I'll just run through the last 10 calls we've done. And these are not cherry picked. These are literally the last 10 things we've done. And I'll just give you a quick, this is what's going on out there. So we had a canoeist who fell out of canoe in a rapids, broke their leg. We needed to access that patient by UTV, coordinating with our SARTEC partners to then hoist and extricate that patient from there right to the PRH helipad. Like that was our last call that we did. We had a youth that rolled an ATV that sustained very significant injuries. We extricated the patient to a waiting Orange Air ambulance, and they went directly to CHEO from there. We had a patient that was way in the bush having a medical emergency that needed to be pulled out. So we went in by float plane in that case and brought that patient out with that. We had a patient that had a very significant trauma to their face, a really quite a bad impaled object that was a threat to the patient's eye that created significant urgency. We ended up extricating that patient as well. And we were the only ones in that case that could get to the patient because the weather was so terrible, no air assets were available. So we were the ones that went in and came out with that patient. What else? We had a youth on a camp trip who had a medical emergency that needed to be brought out from that trip as well. We had a patient who sustained a significant burn while backpacking that was unable to walk anymore, so they came out by canoe in this case. We had a patient on a hike that sustained a leg injury that they could no longer walk, so we were able to go in and splint and provide pain management and then help them hobble out from there. We had a patient on a waterway that was in seizure. We used our boat to access the patient and extricate them from that. We had a reported missing person on a waterway that turned out to be a resuscitation, so we were able to access and bring the patient out and resuscitate them en route out on the boat. And then lastly, the last of the 10 was we had a patient on a hiking trail that rolled their ankle over, it went crack, and they had a very significant ankle injury at the top of a very significant hiking trail that required rope extrication in a litter to get the patient out, which we managed to do safely and get the patient to that. So those are the last 10 calls. There's 90 more of them over the last 3 years that we've been kind of looking at this. So those are some of the ones that we've looked at. I've had the opportunity to train with a number of different agencies who also work in austere environments. So austere is another way of saying wilderness or difficult medicine environments in this past year. And I was fortunate to train alongside some members of truly highly skilled specialty units from the Canadian Forces, from police agencies, from paramedic services, both provincially and nationally. The one theme that keeps coming up when I'm talking to members of these teams is that we as Sierra team, we have a tremendous amount of experiencing working with actual patients. And it sounds a bit odd, but we do more time on missions than we do in training. And that is not the norm for a special team, a special operations unit. You spend all your time training and you do a few calls here and there. We spend all our time doing calls and then we do training when we can, which we schedule through the year and manage to do that as well. So we have lots of hands-on experience. And out of that, every member of our team has become an expert in providing care to patients in really, truly challenging environments. And that makes me, quite frankly, really proud because we are literally taking care to the patient, which is our mandate. That's what we're here to do. So we bring that care and we manage the patient. And that's what everyone on this team is essentially about, and trying to get to that patient to give the care that they can at the time they can. So that's the presentation, Mr. Chair. I trust it was a reasonable overview, and I'll defer to you.
Thank you very much, Commander. It was, I think it was a fantastic overview and gives everyone a really good glimpse into what services we have available here in Renfrew County and up into Algonquin Park as well, as I understand it, even into the nearer parts of Quebec. With that, though, I would once again afford committee any opportunity for questions or comments. I'm going to begin with Councillor Lafreniere, then Councillor Weir, then Councillor Murphy.
Well, thank you very much. Wonderful, enlightening presentation. It's not surprising that you do more hands-on than training, given the geographic challenges in our area. I just wanted to ask, the City of Pembroke has a Marine unit. Do we call on your expertise when we get called, or is that something that happens in municipalities?
Great question. So it happens in the response mechanism, essentially. So depending on what type of response, if there's a patient involved, then we're often tagged to that as the ambulance response, which would initiate that too. So we work together, essentially, to affect that care as much as possible.
That's all, and again, thank you very much.
Thank you. Councillor Weir, please.
Thank you. Through you, Chair. I'm looking at what vehicles and ways you can get to places. In the township of Greater Madawaska, we have a lot of trails and stuff that are motorcycle-only access. ATVs can't get in on them. I don't see any motorcycles in your fleet. However, I have seen a situation where paramedics had to use their own motorcycle on something. And I'm just questioning, does that need to be looked at? Is it something that is required to get into those spots only that motorcycles can and not ATVs? Has there any been thought to that?
So that's a great question, and your area absolutely is all about motorbikes. We spent this summer, we actually supported an event specifically in that area where we piloted a couple of ideas around that, and one of those was to have one of our commanders who's an experienced rider to sweep one of the rides with that as an experiment. And it's something that we may consider down the road. The challenge is, although we need to get to the patient, we also need to get the patient out. So most of the time, if we can't get them out, depending on the situation, we're going to either have to bring that patient out over the ground in a litter, but most of the time when we've had bad calls in that area, we extricate by helicopter. So we tap our resources with Trenton in particular, and we'll hoist them right out of that resource. So that's kind of our approach to that. The motorcycle thing is certainly something it's in the mix that we're kind of exploring. It's difficult to manage a motorcycle-based program in this environment for us, but It's granted, you have a lot of motorcycle single track out there, which is quite remarkable. So thank you.
Councillor Murphy, please.
Thank you, Chair. Councillor Lafreniere said exactly what I would have said. Incredible work that you do. The fact that you have 16 to 20 rostered paramedics at all times, and you're sort of behind the scenes. It's very cool, and I think it's so important that our general population understands that we have this in the works. I just want to be very clear that we didn't buy a helicopter for the chief.
We do not have a helicopter for the chief.
I'm just saying, because that would be something he would want.
Might be handy.
Thank you. Councillor Nicholson, please.
Yeah, thanks, Chair. I'll echo the comments of everyone else. We live in such a beautiful community, great, outdoors, adventurous. Not to have this asset would be a great disservice. So I thank you for what you've been able to do, and specifically from a whitewater perspective, we're surrounded by water. We have these huge lakes, and to see the implementation of a water rescue capability, and being able to treat patients on the water, I think that's an excellent addition to your capacity, and thank you very much.
Thank you. And just to build on that, we learned a lot from the flooding, and that helped build a lot of our capabilities and our ability to do stuff. So this came a lot from that as well. So,
thank you, Warden Emo.
Yes, I'd like to echo all of the good things, and I truly believe this is a service we need to keep and enhance and ensure is robust. However, as part of my duties to rain on every parade is there a means of gaining some revenue? And I think that's something we need to take a look at. I know, our local partners, if they deem a fire to be at fault, then there's the opportunity to levy substantial fines. So I'm wondering if at some point we feel there's a number of incidents over a period of time, whether it's a year or 2 years, where we think the people put themselves at undue risk, and that caused us to spend a lot of time and effort getting them out of it. If there's a means of approaching their personal insurance companies to return revenue, that's not a question for you. If you're aware of that situation somewhere across the whole sector, that's something you can share with us. But I think it's something for us in these chambers to start to ponder for the future. Thank you.
I'll take that one, Commander. That one, as the Warden has said, is not for you. I think it was for me and for all of those sitting facing us as well. I think that is something to consider. Generally speaking, certainly of the 10 that you overviewed here this morning, seemed very much accidental. And it seems to me that if we are inviting individuals, not just in Renfrew County, but broadly in rural Ontario, we are inviting people out to explore, to discover. If we are going to do that, then I think that we also have to provide that comfort level that we will be here should things go horrifically wrong. But that is certainly something I think to take into some consideration. I will come to the Chief momentarily. It almost strikes me that this is almost a return to the roots. Paramedics, if I'm not mistaken, grew out of the medic, which is a military, and those folks were not back at those who watched for a decade MASH. That was the hospital, but there were medics that were out in the field deployed into very difficult, almost inaccessible areas, and they're bringing the care there. Even with respect to our emergent response or our legacy response that I often refer to, the community paramedic program has been such a boon, because it's not important that we get the bus there right away. It's important that we get the staff there that know how to engage with the medical challenges that have prompted the call. So that's incredible that we are doing that. In this regard, it is similar, except that you're generally not in either an air-conditioned home in the summertime or a heated home in the wintertime. It is in the elements. So it has that added factor to it. So I think that it is still very consistent with the roots of what medics and paramedics are, is to get people the care where they need it, when they need it. And I think that this is doing an incredible job, and I think that you're very forward-looking as well. The last thing that strikes me, I understand, and you were quite effusive in your recognition of the training and the learning and the knowledge exchange that our Sierra team has received from our joint exercises. But I anticipate that there is probably some shared knowledge that you are providing from that medical perspective and what the needs of these people are. It's not to get them out of there, it's to get the help to them where they are and get them out safely. So kudos to you, Commander Cruchet, and the entire Sierra team. And I look forward to the next report on this. It is a very high adrenaline part of the job, I anticipate. With that, I know, Chief, you had some comments.
Yeah, thank you, Mr. Chair. And the first in response to the warden, if I could, regarding the revenue recuperation, and that is that this year, for I believe the first time, we were upstaffed for the purposes of Sierra team at events where there was risk. So we're generating at least cost recovery revenues associated with those activities. And I think that that's critically important because two of those occasions were single track events that were being placed, not dissimilar to how we've supported our friends at the Calabogie Motorsports in the past, or where there's significant events at ski hills. So while we're not looking to be punitive towards an individual, we are looking for opportunities at a systems level to not only mitigate the risk, but also stabilize our regular operations. And I think it's an important reminder that when we have a risk-managed approach to calls that can take a significant amount of time or a significant amount of resource, that we're actually then protecting our 911 paramedics to be available for domestic response, and then engaging them or bringing them into a Sierra team response only when it makes sense and is necessary. The historic way of the province was ask them to sit at the side of the road or at the trailhead for as long as it took for someone somehow for that patient to emerge. And in our experiences, that can take quite literally days to occur in the absence of the Sierra team. So it creates efficiency. The second component, Mr. Chair, if I could, and that is as it pertains to the work of the Sierra team, it is a protective approach to our 911 paramedics. So they are 911 paramedics. We crowdsource their availability. Some are on shift, some are off of shift. Some are community paramedics, some of them are commanders that are all putting up their hand, and how it makes most sense, we then operationalize. Again, that's not drawing down on our resource, it's actually protecting our resource. And then we try and optimize the availability of the balance of assets within the system. And that's also important that these are both primary care paramedics and advanced care paramedics. Right, we often hear there's greater advantage to one group or another. This is a team-based approach, and Matt and the entire team have given up many a night. You know, if a call comes in at 3 in the morning, we look for who's available at 3 in the morning, and it may be someone on shift, maybe someone off shift. So a big thank you to all of them for protecting the service, but also protecting the community as part of the process. So thank you, Mr. Chair.
Thank you very much, Chief. And with that, once again, thank you, Commander Cruchet, and off to your training exercise. It should be, I think, mentioned as well, it is not to suggest that there is not substantial training, that they are responding more than they are training. There is a very, very large component to their efforts is training. With that, we're going to once again go back to our agenda report on page 12, and Chief Nolan will go on to item number 2, please.
Thank you, Mr. Chair. I do have one additional item for item number 1 while Matt's still in the chambers, and that is around technology. Could you afford me a moment to reflect on that, just so that committee understands what's coming?
I'll give you a moment and a half.
All right. So many of you have iPhones, many of you have iWatches or Garmin devices, and Starlink recently announced that through LTE systems, as of 2025, you'll be able to purchase a service to be able to call 911 or call your mother via the cell phone that's in your pocket today. That has been an absolute game changer for us, because at one time, only if you had a landline could you call 911. And then cell phones came along, and if you had service, you could call 911. Now on many iPhones, regardless of where you are on the planet, you can request a 911 response through your iPhone. So we have seen automatic notifications of crashes, for example, emerge significantly in the last 18 months. And more relevantly, we're now seeing, I think 3 of the 10 examples that Matt gave you were initiated through an Apple device, same one that's in your pocket, and you can request a 911 response through their call center. That's been a significant point of evolution for us, because we're now working back through Garmin or through Apple to relay messages to the patients, to get more information, to determine the appropriateness of our response and the scale of our response. That didn't exist 2 years ago. And as Starlink comes on board with their full functionality data through any phone, anywhere, that's going to significantly increase the number of patients that we learn of. It's going to change the way we evaluate risk. It's going to change the way that we're communicating with patients. And one of the very important things that we're doing that we didn't touch on in this presentation is that the paramedics are now phoning the patient before we even get there to assess the situation, to provide additional medical instruction should the dispatcher have been able to provide instruction, which they do a phenomenal job in these very complex situations. But we then take it to a clinical level so as to say, you know what, if you do this, this, and this, we'll come when the sun's up in the morning, as opposed to putting our own staff at risk in certain circumstances and being able to get consent from the patient to be able to change that method of response. So just a heads up, we're ahead of the curve on this, and I'm delighted to say that we're ahead of the curve and have some level of comfort in our response, because most jurisdictions, if they're not experiencing it today, even in suburban, urban, and very remote parts of Canada, there will be a public expectation that someone comes when they hit the button, and now the button's actually going to work, and we need to be very conscious of that. Thank you, Mr. Chair.
Thank you very much, Chief. I'm assuming that we are assembling the binder onto how to create a Sierra team so that it can be an off-the-shelf discussion on other paramedic services.
Yes, sir.
With that, Chief, on to item number 2, the Virtual Triage and Assessment Center update, please.
Yeah, thank you, Mr. Chair, and thank you, Matt. Item number 2, regarding the Renfrew County Virtual Triage and Assessment Center update. Pleased to say that on September 9th, we have provided some staffing through VTAC, again at provincial 100% dollars, on Mondays to Petawawa for unattached patients to be able to benefit from the paramedics. The paramedics will lead respiratory, ear, nose, throat assessments, injections, minor procedures, suture removal, tick removal, and so on, for unattached patients in that reason. So despite the fact that Petawawa does an incredible job as a partner in the Integrated Virtual Care Program, which you'll read about further in today's report, there are still a significant number of unattached patients. So we're happy to extend those services there. And really that's a precursor for what we're anticipating soon with the new Eganville base and having the VTAC office in that facility. We know that the need for VTAC continues, as we've had 4 more physicians recently retire from within the county. So that typically results in thousands of patients potentially being orphaned. So with Petawawa coverage and soon some Eganville coverage, we're going to also get off that Highway 17 corridor and be able to service a different geographic population within the county, Mr. Chair. You'll see on the statistics on the next page related to integrated virtual care and the number of patients with over 6,000 patients through our integrated virtual care. So the reminder on integrated virtual care is it's a sister program funded through VTAC, whereby patients typically in the catchment area of the Petawawa Centennial Family Health Center are offered to have a virtual named physician and have access to all of the allied health and services that are provided through Petawawa. This is a very innovative approach. They're using funding that would otherwise have been spent on physicians who had been recruited. The province gave special dispensation to be able to use those unspent dollars because they're unable to attract additional physicians for that complement and be able to extend virtual named physicians. So they're no longer orphan to patients. They actually have a doctor. They can reach their doctor virtually. But if the doctor requires a PAP, for example, or someone to do a certain procedure, they can either direct them to one of the community paramedic clinics or direct them to the allied health specialists within Petawawa itself. So that's a very important program that Judy and the team do an incredible job, Judy Hill at Petawawa, in managing for us. Item number 3, Mr. Chair, the Models of Care Initiative. In many respects, the models of care that are listed here, which is the palliative program, the low acuity disposition, or otherwise known as treat and refer program, as well as the opioid withdrawal program and mental health and addictions, are really about solidifying what we've already been doing, but officially registering with the province the models of care that we've done. So we've done these models, many of these models of care, since before models of care became a thing at the ministry. And so we've now been able to capture much of the activity. And if you look at the palliative care program, much of the national palliative care program led by Amber Hultink, one of our commanders, we're now registering with the province to say, yes, we're doing what we've always been doing. However, with the base hospital, we can have a greater level of integration and greater consistency in the way that we're delivering that program. So Matthew Grenier, who's at the back of the room, and his team have been working very closely with our partners and the ministry to officially roll out these patient care models. Again, palliative, low acuity, or treat and refer. The goal of treat and refer is that if the paramedics are with the patient and they're able to take the emergency out of the situation and be able to also provide additional treatment, but connect them to other services. There's a medical consultation line through our base hospital. There's the VTAC program. And if the patient says, you know what, you've been able to help me through this, you've been able to get me a prescription, get me a diagnosis, get me a referral, I don't want to go to the hospital anymore, which makes perfect sense if we're able to provide those services in your own living room, then this, under the Ambulance Act, gives us the ability to say we agree and we support your choice, not the typical Miranda, which said you're refusing care and we're recommending that you go to the hospital. That's quite archaic as an approach, and this kind of corrects that approach, if you will, with provincial support. One of the things that these chambers have advocated for with the ministry for some time. So we're pleased that there are now mechanisms by which to address these. And the second component of models of care is that we have new referral pathways within the community paramedic program itself, which again include hospital diversion. You remember during the pandemic, we were connecting patients to VTAC in their own home to avoid them having to go to the hospital, right? They chose to not go to the hospital. That is a logical next step. Very few, in fact, less than 20% of the patients that call 911 need to go to the hospital on an urgent basis based upon their C-test level. So that means 80% of those patients that call 911 can either benefit from paramedic expertise, assessment, treatment, and care in the home, layer that in with connection with primary care. Then you ask the patient, do you want to go to the hospital now? Because they have the evidence, because they have the experience behind them. So these hospital diversions are about protecting our resources in hospital, but it's also about changing the way that we respond and also how we see ourselves. If 20% of our patients need to go to the hospital with some urgency, then why is it that we're sending an ambulance with 2 paramedics to every 911 call? The only reason we do that now is because the rules say we have to. But if we can best risk stratify those patients and send 1 paramedic to be able to assess the patient, triage the patient, and ultimately with the intention of giving them the care that they require when and where they require it, then that can also change how we position ourselves as a paramedic service going forward. And I think that maturation is going to have to come knowing that 2 paramedics and an ambulance need to be protected for those 2% of patients that have to go somewhere now, your traumas, your STEMIs, your strokes. But that 18% of the balance of those urgent patients could benefit from care to take the urgency out of that situation. And the balance most likely don't need transportation urgently, and many of them don't require transportation at all. It does also bring into view the role of non-emergency transportation and what other options. Ottawa, for example, is moving forward with a program whereby they will call you a taxi to be able to take you to the pharmacy, because it's significantly less cost, it's less time, and if it's what you need and the pharmacist is able to provide you that level of care with their new abilities, then that just makes sense from a systems perspective. So we're working through that process, knowing that we don't have all of those options available to us today, but there's some logic in how we utilize the technology and the decision support to be able to do that. And in being able to roll these out with staff, I think it's important to note that through Ontario Health, a partnership with Ontario Paramedic Services, bringing in a new revenue for us of over $80,000 so that we can bring our paramedics together through the continuing medical education program and pay for their time to be trained in these models of care at 100% provincial dollars. So we're very pleased that work is ongoing, Mr. Chair, and that we're able to draw down some resources in a collaborative approach with the Ottawa Paramedic Service.
Can't double tap. Thank you very much, Chief. We're going to go back through the information items. So, committee, if you return to page 12, any further questions on the Sierra team? On the Renfrew County Virtual Triage and Assessment Center update. Councillor Murphy, please.
Just to say, these numbers are staggering. Like, it really is incredible what you're doing, and I'm really excited about the potential of a clinic coming to Eganville. I think it'll be widely used. Thanks.
Thank you. Any further question? Warden Emo.
Thank you. Just if you could offer some explanation as to the headings on top of the charts where it talks about, especially the first chart where it talks about number of person visits booked with a paramedic at a clinical assessment center. Does that include the link to a doctor, or is that then generated referral to the doctor in the future with the paramedic in the room?
Chief Nolan.
Yeah, thank you, Mr. Chair. In fact, that might be one of three circumstances. So if we take the April at 232 as the example, during that month, 5,833 people called the VTAC line. The medical receptionist is able to address a number of those circumstances whereby they redirect to a pharmacy, for example, or provide access to virtual mental health or other services. And that's a vital service, and I think those staff are often under-recognized for their impact in health system navigation at source. This isn't you call and no matter what you talk to a doctor, no matter what you see a paramedic. It's that we have a unique opportunity to optimize the services and the expertise that already exist in the community. In that same month, the number of booked virtual visits with a physician was then the 3,535. That's important because that's the number of patients that, after speaking with the medical receptionist, then required the additional support of the physician to be able to see them. Of those physician visits, a portion of the 232 in-person visits occurred, but we also have in-person visits through two other pathways. One of those pathways is us reaching out to patients that we know that don't have a primary care physician, haven't had cancer screening, for example, haven't had cardiovascular screening, and we invite them in for an appointment with the paramedics to be able to essentially have a mini physical, for lack of a better term, to be able to do a very structured assessment by the paramedics. So that's one lane. The second lane is we have the opportunity, I'll use pediatric respiratory clinics, for example, coming this fall. We'll have a number of patients who may call VTAC or may know that they can call VTAC and book a time to bring their child directly into the assessment center to have a physical workup done by the paramedic, and only if necessary will that paramedic initiate a visit with the physician for further care. And this is a program that we've initiated with CHEO. So if you're from Renfrew County, you have a child, they have mild respiratory symptoms, then you can bring that child in and we'll help that parent or that child work through the assessment as well as the most appropriate evidence-informed practice for that client. The third group is really those that go through the medical receptionist, go to the physician, and the physician says, you know what, I really want someone to listen to your lungs, check your oxygen saturation, and do a more comprehensive physical exam, and then call me back with those results so that we can establish a care plan for you. So we might call you to come in for a physical. You might come directly to the paramedic because that's the most appropriate workup before or if a physician consult is required. And then the third group is after a physician virtual assessment, they can then direct you to one of our clinics and the paramedics will see you typically same day to complete your workup and then close the loop with the physician to establish a care plan.
Follow-up, Warden Emo.
Thank you very much for that. Is it possible to get every 6 months or so the annual stats from date of inception? Because I believe that it's over 100,000 calls, and so I think we just have to keep that in our vision as we move forward. And then the other piece is possibly we should be reaching out to Cogeco and have them do about a half-hour program outlining, the services and the branches of care for VTAC, and then have that on our YouTube channel and then also through all the municipalities, because I think people aren't aware of how vast a spectrum of services that could be offered or are offered. And it may offer some reassurance to the community as they note, they keep hearing my words of doom, we're 30,000 people without doctors, we're gaining 10 more, or 2,500 more people joining the doctorless list. And so I think we need to offer some reassurances. So this might be the opportunity and the time to have a more structured communication about what we're offering and blast that out as best we can, just offer reassurance to our community. Thank you.
Thank you. Councillor Lafreniere and then Councillor Nicholson.
Thank you. So I understand the need to divert patients from calling 911 and going to the emergency departments. And I also understand the necessity to provide services to those unattached individuals. There's no question this is a needed service. I guess my question is funding. So the more we divert and the more we fill these gaps, the more workload we're giving to our own paramedics, VTAC, et cetera, the funding for this. So I'm wondering the question around diversion and increase in workload. What is the funding formula for this? Is it all going to be, like I know some of it you're looking at the province to pick up, but how does that work? So when you're diverting work from hospital workers, where does that cost burden go? And I just want to understand that more, because I'm not debating whether it's needed. It's absolutely needed. But who is going to be paying the bill? When it's the hospital, I would imagine it is funding. Doctors get funded to treat patients. So if you could just explain that to me so I have a better understanding. Thank you.
I'll take the first. So VTAC is 100% funded by the province. It is part of the health system, which is earlier in the presentation, unrelated to this, but Mr. Kelly had made reference to where our lanes are. So our lanes have become blurred a little bit, but the legacy of the 911 system and has typically been funded 50% or all but 50% from the province. I think from the municipal perspective, I think the City of Pembroke is 15%. and the county of Renfrew is 35. That's the formula for the legacy system. VTAC is 100% funded by the province. That is not coming out of any municipal levy. But if there's anything you wish to add to that, Chief Nolan.
Yeah, thank you, Chair. I think what I will add is what it's saving, and you can argue the definition of savings in the healthcare system in many ways, but we know that our partners at Pembroke Regional Hospital, for example, were presenting recently at AMO, and they have been able to demonstrate clearly that the proportion of patients who present to their emergency department with low acuity, so the less sick of the crowd that would go to the hospital, is impacted because of VTAC, which allows them to use the resources that they already have and that they're already funded for to be able to better care for and manage their capacity for those sicker patients who should be in the hospital. The same can be said from the 911 side of the house, and we know that as a result of VTAC, not only is there a reduction in 911 calls from that same population who, and I think it's a good reminder, in Renfrew County, we don't have an urgent care center, right? We don't have walk-in clinics. If you're rostered and have the luxury of being rostered to a patient, then you should have same-day access based upon the capacity within the primary care system. But we know that even in those circumstances, that's not always the case. So if you don't have a family doctor and you do have, a burning issue that might prevent you from going to work tomorrow, that's an economic impact. Or having to take the day off tomorrow to be able to care for your mother because they don't have a primary care physician. Your only choice is to go to the emergency department or call 911. So this is what we call the third door approach, which is everybody has access to medical receptionist, consult with a primary care physician, and a physical assessment by paramedics. And I didn't mention it in the report so as not to distract from it, but an important context. If you can't get to our clinic, our community paramedic will come to you in your own home. And I think that when we think about how we layer that care, as well as provide remote monitoring for ongoing assistance, this is a very comprehensive 100% provincially funded program, but it also significantly retains capacity in our system to do a better job and not be having to come back and apply real financial pressure in these chambers to the levy and ask for additional resources that are our 50-50 responsibility or are a pressure from a long-term care perspective because of crisis placement that we might have been otherwise able to avoid by having the prevention measures in place. So this is the classic, an ounce of prevention, is a pound of cure. I think that those are important notions, and that's really the approach we're taking. Thank you, Mr. Chair.
Thank you.
Thank you. Just while we were on this, I was going to say my remarks till the end, but this has breached where I was going to go with this. I'm all the way back to Councillor Murphy's comments. I think that this is outstanding, that the VTAC is now offering a walk-in in Petawawa, that there is a view towards doing this in Eganville. And it has been part of the evolution of the emergent response that typically people associate with paramedics towards the evolution to what the County of Renfrew is now, because it is indemnified to that continuing emergent response. Going all the way back to what they were first called, I think the Health Links program looked after the frequent users of emergency response. And these were a certain percentage of the population that we were responding to on a regular basis that were generally challenged because of access to primary care. So I think it's important to remember, while these are great, they are now substituting for a buckling system. The last number that I heard, this was back when we were in fact striving to make VTAC a permanent funded agency or a permanent funded vehicle for our community. We were using 30,000 then, and that's probably 3 years ago, maybe 4 years ago. I don't know if we have any current number. It is somewhat of a moving target to nail down what that is. But we have, as the warden has said, we have responded to a need of our community, but we didn't create the need of our community. The need has arisen because our system is buckling. The province is now, we just at our last council meeting passed the joint resolution of AMO-OMA, which was respect to primary care. In this instance, it was to physician care. I'm not tied down to physician care. I am tied to primary care. And that is what integrated virtual care is providing. Through a virtual means, it is still that wraparound access to primary care. But VTAC is a godsend because what we're supposed to be getting in this province is not there. The reason that the hospital ERs are buckling is because the system is problematic. So while it is a godsend to be able to respond to our community, while we must acknowledge that the province is funding this at 100%, it's still not clear to me if the province is viewing this as the chrysalis stage. Is there a butterfly to emerge from this, or is this simply propping up a system that is incredibly challenged right now? I don't know the answer to that, but I think that that is crucial to our population, and I think it is something that is really occurring to our population. There is barely a day goes by that we are not confronted somewhere in the province with a temporary closure to the ER or some issue with respect to access of medical care. So I think that it's important to keep that in mind. Also, I'm going to go first to Councillor Nicholson and then to Councillor Purcell.
Thank you, Chair. This is a very important topic, so I appreciate you allowing all these extra questions. But the first, I have two, if I might be able to. The first one, just when Chief Nolan was speaking to Warden Emond in his response about the numbers in that table, one of the categories or groups or classifications that he kind of spoke to led me to believe that we're almost doing case management for very specific complex patients. Is that the right interpretation?
Chief?
I would say by the nature of chronic disease, Chair, the answer is yes.
Good.
In that if you're unattached and you have a complex chronic disease, you may have caregivers that may not be a primary caregiver, right? It might not be a physician nurse practitioner. It might be home care. It might be other parts of the system that are attempting to stabilize or improve your quality of life. By nature of the community paramedic program itself, it is designed to treat typically older adults with complex chronic disease, to stabilize their condition, to keep them home, to prevent them from being a crisis placement into long-term care or calling 911 or going to the hospital. That was our original mandate. The MESA program is another form of the community paramedic model in that it's typically now serving younger adults with complex clinical and social disease that require a different type of intervention. But by no stretch are these simple tasks. Every person is complicated in their own way, and the complexity of their disease is typically tied to the progression of their disease, and we want to catch disease as early as possible to have the greatest impact. That's often hard to measure in terms of what the impact is. It's very easy to measure cardiac arrest and how many people lived or died based on minutes and seconds. It's very difficult to fully appreciate the impact of catching something early and something not happening because you caught it early, and that's the notion of community paramedicine in all of its forms.
Yeah, and public health. So, Chair, if I could continue?
Yeah, and just before I come back to you for your supplementary, Councillor Nicholson, just doing some quick math. So on that chart, just on the April numbers alone, so 40% of those calls didn't lead to a physician assessment, and of the 60% that did, only just a little over 6% of them actually led to a walk-in assessment clinic. So I think the system is functioning as it was perceived to function, and recognizing that in the broadest definition of triaging, there's a lot of people don't need substantial component of the health system. Anyway, back to you for a supplementary.
Thanks, Chair. And I just to add Chief Nolan's comments, I think it's important for us to have that safety net, because right now there is no other organization offering that. The medical system is just not capable of it. It's scrambling to keep up with, I wouldn't even say keep up. We heard on the radio today on the drive-in, they were talking about cardiologists taking appointments, referrals from probably ERs, but then providing primary care to cardio patients because they've got no family doctor. So the system is just basically scrambling. So that would lead me to my next question. It's important for us to appreciate all of these numbers and the processes in place and the proposal to go with a CAC in Eganville. I think that's a great next step. But the bigger picture, and Warden Emo mentioned it, is where are we at with our own doctors? Do we truly have our finger on the pulse as to how many doctors are leaving in the next year? How many patients are going to become unattached? Do we know when the next chess piece is going to move so we can be prepared and have the things in place in order to be able to respond effectively for our community?
If I might, I'm not entirely sure it's a chess piece. I'm thinking more of the game Kerplunk. You might remember that, where there were straws put through a tube. And I'm wondering when the whole thing is going to fall through because one more of those straws got removed with that, Chief.
Thank you. And maybe we can help Ev with the spelling of Kerplunk. It might not be in the standard dictionary. But I would say, while chess is the analogy, we will continually be surprised. There is a highly competitive environment within medicine in terms of recruitment and retention. So while you might be approaching retirement age and have some degree of predictability in that, we know that our older physician group tend to carry much larger patient populations than even a single physician or two physicians following them to take on that caseload. So I don't have the exact numbers, but I would submit to you that in more cases than not, it takes two new physicians to take on the caseload of one retiring physician. We also have a significant number of physicians, as our hospital partners also see, who are leaving the area because they're being poached by other areas or making life choices otherwise. And at Garrison Petawawa, for example, we see availability of physicians, families, and we have a pretty considerable tide in and out in terms of our population of need. So while Ontario publishes one set of numbers in terms of orphan patients, we went through an exhaustive exercise with Dr. Fitzsimon to actually try to get our true number of orphaned patients within the county. And that number is continuing to climb, despite the fact we have integrated virtual care, which is trying to keep up, and as well with physician retirements, physicians coming and going. And our population, while it's a pretty slow increase, there is a considerable number of people that come and go. And it's the coming and going. It's not the straight increase that matters, because if you came and you were a patient of Dr. So-and-so, and now your spouse has been posted somewhere else in the country, and you have a new person coming in, that can change our number without changing our population. And I think that those are some of the drivers that are fairly unique to the County of Renfrew. We're also seeing a lot of people who lived in Ottawa, had a cottage in the county, and are now living at the cottage and are now hours away from where their primary care physician was and need the adjacency. So there's also that type of migration in and out in the county. So do we have our finger on the pulse? As best we can. I know that Craig leads the Health Human Resource Strategy Group of the Ontario Health Team within our area, and I think that that's an ongoing conversation, not only with physicians, but all allied health. And we know that recruitment of physicians and other healthcare providers is a fluid situation, but suffice to say, our population need continues to outstrip the availability of the human resource capacity within primary care. The province is looking to change the channel and saying, okay, well, it's maybe you don't have to have a physician, maybe you need to be a part of a health team to be able to access services, and there may be some truth in that. But when we look at the straight line needs in the community, we're getting older, we're getting sicker, and our needs and our expectations of this next generation eclipse anything of previous generations. Where your or my parents or grandparents might have put up with certain things, we now measure, days and minutes of wait time on cancer lists that didn't exist 5, let alone 50 years ago. Mr. Chair.
And final question to Councillor Purcell.
Thank you, Chair. I just wanted to comment. I had the pleasure of attending as a City of Pembroke presentation to the Ontario Medical Association on August the 20th, and that was through AMO, along with the hospital CEO Sabine Mersman, as well as Mayor Gervais and our CAO Dave Unruh. It was quite evident, based on the information that was provided in terms of primary care attachment, that 1/3 of the residents of Pembroke, an area, do not have a family physician, and that 38% of patients that are coming into the emergency department at Pembroke Regional Hospital don't have a family physician. So those are stats that were provided by PRH. I guess some of the other challenges that we're seeing is that some of the family health teams, or the largest family health team in Pembroke, which has 9 physicians, does not have support from family health teams. So they don't have those allied health staff services that are to attach to, in terms of the providing physicians to the primary care of the patient. So again, I think what we were discussing right here, it's very important that we truly understand that that there's an increase in terms of PRH, in terms of the acuteness, in terms of individuals that are coming into the emergency departments, and that's attributed to Renfrew County, the VTAC, taking on some of the virtual care programming and really addressing the low acute visits and removing those from PRH. So we have some work to do, but believe me, the Ontario Medical Association was very interested in the presentation that was provided by Sabine Mersman, and looking at some of the gaps that we're seeing. But again, I think it just shows the importance in terms of the VTAC, in terms of making sure that we continue to provide these types of services, so that way we can reduce some of the visits to our emergency department. I'll give you another example, is that in terms of psychiatric services. So in terms of psychologists, 1.5 is the average that we have for 100,000 patients within the Renfrew County. Meanwhile, that's the average is actually 7. So we need to do some work there. And of course, attracting physicians is not just a Renfrew County problem. It's a problem right across the country, in fact, internationally. So I think we have, I think we need to continue, putting pressure on the provincial governments to fund adequately the health services, and making sure that we do everything possible to attract physicians within our local area. So thank you.
Thank you very much, Councillor Purcell. So I'll be quite frank. The chair vastly underestimated how long today. I thought this was going to be one of our shorter agendas. Otherwise, I would not have drank as much coffee and water. So in the interest of brevity, and acknowledging that we're even, you may be aware, we are piloting a new program this morning to try and move the committee meetings along. We're going directly from item 3 to item 5. We're going to skip number 4. It's the Nigel Tufnell allowance. So we're going to go directly to resolutions. So if you had any questions on levels of care or models of care, you'll have to ask the chief after on your own. We're going to go into resolutions, please, Chief Nolan.
Item number 5, resolution recommendation that Health Committee recommended Council approve the amount of $170,599.86 and $121,078.08 be transferred to the Community Paramedic Reserve, consistent with the provisions outlined in the transfer payment agreements, Community Paramedicine, Long-Term Care, and VTAC, and that Finance and Administration Committee be so advised. Mr. Chair.
Thank you very much. I would seek a mover, please. Councillor Lafreniere, seconded by Councillor Purcell. Background, Chief.
Background in that for the program years ending March 31, 2024, both the CPLTC and RC VTAC operations initially end of the year reporting surpluses of 170,599.86 and 121,078.08 respectively, and that the transfer payment agreements for these funds provide the ability for the county to charge administration fees and other indirect costs in order to maximize their utilization of this funding. Staff are recommending that revenue generated by these administration fees be transferred to the Community Paramedic Reserve for future use. Mr. Chair.
Thank you very much. Questions, comments? Seeing none, all in favor? That is carried. On to bylaws. And just a reminder, there was also an addendum sent out. There was a second item on the addendum, but we'll go to bylaws, please. Chief Nolan.
Item number 6 in bylaws, Mr. Chair, recommendation that the Health Committee recommends to County Council the authorization be given to proceed with the purchase of 5 power load stretchers and 5 Power Pro cots from Stryker Canada for a net cost of $327,116.63 under the non-competitive purchase criteria in policy GA01, procurement of goods and services, and that the County of Renfrew County Council adopt a bylaw to execute the purchase.
Thank you very much. Once again, a mover, please. Councillor Weir, seconded by Councillor Wilmer. The background is lengthy. Everyone had an opportunity to read that. I don't think we need to go through that piece by piece. Any questions or comments? Warden Emo.
Very brief. I understand LAS has ventured into the procurement of ambulances. So if in a few months, if you could give us your assessment of that, I'd appreciate it. Thank you.
Thank you. Any further questions or comments? I had two. I'll start with a comment. I noticed in the bylaw, in the second preamble clause, you'll find this, committee, on page 17. It says, and whereas the County of Renfrew deems it desirable to purchase of 6 additional Stryker Canada for the purchase of 5 Power Load and 5 Power Pro cots. I think that's probably a typo. I think the 6 should somehow be excised both from that, and in fact in item number 1, numbered number 1, it also says 6 additional Stryker Canada, but it does clearly identify it is for the purchase of 5. That's just a comment. The second one is the question is, what percentage do we anticipate the increased cost of these units given the direct purchase as opposed to the integrated purchase?
Thank you, Mr. Chair. And to your comment, yes, 6 has been struck, and we've sent the revision to Evelyn. So for County Council, it will be revised. And Deputy Chief Libby will speak to your second question.
Thanks, Chief. And to your question, Chair, when we're looking at purchasing these items currently, the pressure is that as of October 1st, we have pricing that's locked in. The pricing that we're achieving here is very similar to what we were able to do through Demers when we were purchasing the stretchers in conjunction with the ambulance. So the reasons before committee today is to get in before that October 1st deadline, in that there will be price increases. For example, the stretcher that we're currently purchasing and using in our entire fleet is based on this stretcher. They won't be carrying that. We won't be able to order it post October 1st, and that will be approximately 25% price increase to move to this new stretcher after October 1st. So,
okay, thank you. Anything further? All in favor? That is carried. Moving on then to the addendum. This is item number 7 with respect to delegated authority. Chief Nolan.
Yeah, thank you, Mr. Chair. And item number 7 in delegated authority is the following items were approved under bylaw 98-24 delegated authority bylaw. The first of which you'll identify on item 125-24 is related to provincial one-time funding of the amount of $214,032. And the second, Mr. Chair, financial agreement is related to the smart transportation funding that was referred to earlier in today's document, related to the training costs for treat and release. That expires on December 31st, 2024. So we'll be moving those funds across now.
Okay, thank you. There is no resolution attached to this. The authority has been delegated. I think, though, that this would be numbered and listed in the bylaws at the end of the month, that council then approves the list of bylaws. Is that correct, Mr. Kelly?
To you, Chair, no, not entirely correct. But they appear as part of my report to council at FNA. There are bylaws listed in the bylaw book now with the letter D on them, just saying they're delegated authority, but the council does not approve these bylaws.
Okay, so we have bylaws that council does not approve.
That's why it's a delegated authority bylaw.
Okay. With that then, I would seek a motion to accept the emergency services report as a whole, please. Councillor Yon, seconded by Councillor Lafreniere. All in favor? That is carried. We are going to take a very brief, we will reconvene at 11:35 for the long-term care report. Welcome back, everyone, keeping this moving right along. We would now go to the long-term care report. You can find that on page 18 of today's agenda report. With that, Mr. Blackmore, please take us through.
Thank you, Chair Donahue. Through you to committee. Item number 1 is the 2024-25 Comprehensive Minor Capital Program. And I must admit, when I first saw the announcement, I thought, oh, here we go again. It's been new money, just like we received in April, which is that one-time funding of capital. But unfortunately, this is money we were anticipating in terms of ongoing capital supply for 2024-25. And the calculation methods for each of IPAC, Infection Prevention and Control, minor capital funding, and falls prevention equipment funding is detailed in number 1. Item number 2 summarizes the Ministry of Long-Term Care inspection conducted at Miramichi Lodge, carried out over a period of 7 days in July. We received 2 written notifications, and 2 compliance orders were put back into compliance. And the link is contained below. Item number 3 details an inspection conducted by the Renfrew County and District Health Unit at Bonnechere Manor, with all inspection items observed to be compliant. Congratulations to the Food Services Supervisor, Kayla McNulty, and her team. Resolutions.
We'll stop at the information items. Thank you, Mr. Blackmore. We will review once again on page 18 the Comprehensive Minor Capital Program. Any questions or comments? Councillor Nicholson, please.
Thank you, Chair. Just a question on the Falls Prevention Equipment Fund. I just know that when I listen to Ontario Health Teams, falls prevention, the pathways, all of that is a significant effort that they're making in the community. Is this $100 per eligible bed something, an investment that it could be considered outside of long-term care for assisted living circumstances, or something to that effect where we may be able to economize on a policy or initiative?
Thank you, Chair. Through to Councillor Nicholson, this funding is strictly for within the long-term care homes.
Thank you. Anything further on item 1? Warden Emo, please.
Just a general question, which I'm famous for. It kind of looks like they're dipping their toe into a per-bed funding scheme. Any sense that they're going to review the success or non-success of this and take the lessons learned?
Just, I will call upon Mr. Blackmore. I'm not entirely sure that this is dipping their toe. We've had numerous per-bed funding envelopes, and in fact, one of the notes that I had is this was extra budgetary funding, and I believe Mr. Blackmore addressed that and said, no, in fact, this has been incorporated. This was anticipated funding, but I think there's quite a number of envelopes that are on a per-bed basis, correct?
Thank you, Chair, and indulge me, but Warden, were you referring to overall global funding in terms of replacing MDS?
Yeah.
Yes.
Yes.
So we've had some conversations with that in that regard, and I was fortunate enough to participate in a focus group. And at this time, the ministry is sticking to the MDS or acuity-based funding, although there is a modification coming up to the MDS assessment tool, for which they're seeking early adopter homes.
Thank you.
Thank you. Anything further? Moving on to item number 2, the Ministry of Long-Term Care Inspection Report at the Lodge. I see none on the RCDHU inspection at the Manor. Please express Mr. Blackmore, our committee's appreciation on the clean bill of health and our commendation. Moving on to resolutions then, please.
Thank you, Chair. Through you to committee, a resolution. Number 4, Registered Nurses Association of Ontario International Affairs and Best Practice Guidelines Center. A recommendation that the Health Committee recommends that County Council authorize the Warden and Chief Administrative Officer, Deputy Clerk, to sign an agreement with the Registered Nurses Association of Ontario for nurse quality indicators for reporting and evaluation, known as NQUIRE, data system usage agreement for non-best practice spotlight organizations, and that the County of Renfrew Long-Term Care Homes, Bonnechere Manor, and Miramichi Lodge will monitor and evaluate the outcomes of the RNAO best practice guidelines and the RNAO clinical pathway license agreement toward achieving improved resident care planning based on RNAO best practice guidelines, BPGs.
Thank you. I would seek a mover, please. Councillor Wilmer. Councillor Yon. The background, I think, is, in the interest of expediting, the background is attached. Any questions or comments, committee? I just had one. I'm confused at the first paragraph on page 20. There is the comment regarding de-identified quality indicators, and I'm quite perplexed at how to understand what de-identified quality indicators means.
Thank you, Chair. So for purposes of sharing data, it's de-identifying means resident names are withheld and potentially facility name as well in terms of benchmarking with other participating facilities.
So essentially anonymized then. Okay. When I had read it, I was wondering if these had been indicators that were no longer deemed to have utility in arriving at this, but it is simply to anonymize the data. Okay, thank you. This would be then metadata essentially. Any further questions or comments? Seeing none, all in favor? That is carried. I do note, perhaps as a suggestion, unless there is something burning, we now have business cases 1, 2, 3, 4. If there are questions, perhaps we can, unless they are specific to any one of the positions, if we can wait until we go through, no, I guess we can't. Each one of these is a resolution unto itself. Okay, so disregard. Carry on, Mr. Blackmore, please.
Thank you, Chair. Through to committee, just to preface that each one of these 4 business cases, they're all unbudgeted items. But at the same time, we'd also received significant funds by way of our acuity increase in funding at 6.6%. So we typically budget around 2.5%. So this is an opportunity to utilize those funds to augment some positions we've been looking at for some time that we have not been able to increase. Because as you may be aware, over the last number of years, we've received numerous funding announcements that are tied to specific positions, whether that be RN, PSW, RPN, but not really a lot of opportunity for some of these ancillary positions. So with that, number 6, business case, physiotherapist assistant, Bonnechere Manor and Miramichi Lodge. Did I skip 6? Oh, yeah. Sorry, I scrolled down too far. Number 5, business case, recreation programmer, Bonnechere Manor and Miramichi Lodge. A recommendation that the Health Committee recommends to County Council the approval of 2 full-time complements, one at each Bonnechere Manor and Miramichi Lodge, designated as recreation programmer, and that the Finance and Administration Committee be so advised.
Thank you very much, Mr. Blackmore, and I do apologize. That's on me. I know that we were templating or piloting this new Nigel Tufnell, so this one's on me. Any questions or comments? All in favor? Carried. Oh, sorry, Ms. Van Starkenburg.
Yes, we don't have a mover and a seconder yet for this.
Oh, well done. I'm trying to expedite too much. Mover, please. Councillor Lafreniere, seconded by Councillor Wilmer. Once again, all in favor. Retroactively, thank you. Moving on then, Mr. Blackmore, please.
Thank you, Chair. 6, business case, physiotherapist assistants, Bonnechere Manor and Miramichi Lodge. A recommendation that the Health Committee recommends to County Council that the physiotherapist assistant staffing complement at Bonnechere Manor is increased by 1 full-time physiotherapist assistant position, and staffing complement at Miramichi Lodge is increased by 2 full-time physiotherapist assistant positions effective November 1, 2024, and that the Finance and Administration Committee be so advised.
Thank you very much. Seek a mover, please. Councillor Purcell, Warden Emo. Questions, comments? All in favor? Carried. On to item 7, please.
Thank you, Chair. 7, business case, Assistant Food Services Supervisor, Miramichi Lodge. A recommendation that the Health Committee recommends to County Council the approval of 1 additional full-time staffing complement designated as Assistant Food Services Supervisor, Miramichi Lodge, effective October 1, 2024, and that the Finance and Administration Committee be so advised.
Thank you once again. A mover once again, please. Councillor Yon, seconded by Councillor Lafreniere. Any questions or comments on item 7? I just had one. I note that the business case, the discussion, which can be found on page 54 if you wanted to see it, cites the conversion of current part-time complement. So presumably these part-time positions will now be redundant or filled on a full-time basis. However, they don't appear to have been netted out of the financial considerations. I wonder if you could speak to that, Mr. Blackmore.
Thank you, Chair. For clarity, perhaps this could have been easily worded monitoring matter at Miramichi Lodge, given that currently we have the assistant food services supervisor is an individual that's doing dividing their hours between the two homes. So by virtue of hiring full-time at Miramichi Lodge, each home will have its own full-time assistant food services supervisor.
Okay, thank you. That does provide some clarity. Anything further? All in favor? That is carried. On to item 8, please, Mr. Blackmore.
Thank you, Chair. Item 8, business case Laundry Aid Miramichi Lodge. A recommendation that the Health Committee recommends to County Council the approval of an additional 624 hours per year of part-time laundry aid hours at Miramichi Lodge be approved effective October 1, 2024, and that the Finance and Administration Committee be so advised.
Thank you once again. Once again, committee, seek a mover, please. Councillor Murphy, seconded by Councillor Nicholson. Any questions or comments on this item? All in favor? That is carried. Thank you. I'd seek a motion to approve the long-term care report as a whole, please. Councillor Purcell, seconded by Councillor Wilmer. All in favor? That too is carried. I should have noted at the outset, and I do commend staff, clerk perhaps, I think that it is very refreshing to actually have all of the resolutions kind of front-loaded just as a reference point. As a reference, anytime in the future, you don't need to go hunting through the report to find the actual business that was conducted at the meeting and the motions for approval. I think that that's a great idea. Moving on from that then, item 11 is the Board of Health minutes. There were none at the time of mailing. I believe the Board of Health reconvenes again at the end of this month after a summer hiatus. Is there any new business this morning? Councillor Nicholson.
Thanks, Chair. I'm not sure if this is the appropriate way or method, but I'll get counseled on that very shortly, I think. I'm interested in knowing more about accessible transport, non-urgent medical care transport, home and community care transport within the county. And I'm wondering if that's something that we could either ask experts to come in and speak to us about or obtain some additional information.
So I think that this is germane, at least to get this onto the table. And perhaps you can provide a little bit more of the context you had in a very brief conversation earlier this morning. Councillor Nicholson, you had identified that there seems to be, at least from my perspective, a broadening in what is considered transit funding. I think that those in the Pembroke area are familiar with the Handy Bus. Those in the Renfrew area are familiar with the Sunshine Coach, which to my knowledge are the only two transit agencies that are provided funding through the provincial gas tax. But I think that you may have knowledge in one of the other boards that you sit on. And again, I think that this is at least to broach this subject that staff may investigate.
Yeah, thanks, Chair. There's a third entity now. Petawawa has also been approved for gas tax use for a home and community support access vehicle that they have. So there's two not-for-profits, the Handy Bus and Sunshine Coach. Petawawa Municipality is running their own using MTO gas tax. And then Care4 has about a fleet of 22 vehicles that are dispersed across the county, funded by a variety of different means. And the sustainability of this and the insurance of making sure that that kind of transport is available for all members of the community is something that I think we'd like to shine some light on.
Okay, so the new component that I was hearing there is the municipal corporation of Petawawa, of the town of Petawawa, is now a provider of that? Okay. So perhaps just as the new business, that's kind of being put in front of staff to investigate. Mr. Kelly, what's the appropriate means? Should that be through a notice of motion? I think at this point it's probably more exploratory than with any direction to do something. How would you proceed or recommend?
Chair, I would suggest you're at committee, so we don't usually do notice of motion at committee. Just a motion at committee is a notice of motion. It's not something the county provides, however. So this is, as you've already noted, this is a service provided by our allied partners, I suppose, if you want to call them that, or there are teams at the OVOHT that have looked at home care services. I sit on a number of committees on the OHT, and it's being discussed at the OHT level. I have to determine how we can bring a report together, or at least someone to speak to it that knows all. So maybe even direction to staff or motion to direct staff to either bring back a report or have someone bring back a report on this or a conversation in the future.
Sorry, and I will come momentarily to a follow-up, Councillor Nicholson. So I'm certainly sensitive to essentially this being outside of the scope of the County of Renfrew, and maybe more germane, particularly in this instance, as it is a lower-tier municipality. I would suspect that there is probably, when this gentleman is in the room from Petawawa, Councillor Service probably is quite knowledgeable on that. But I'm struggling a little bit. Is that still, at least to understand what the roots of this are? Mr. Kelly, are you suggesting that that would be within an appropriate utilization of county resource?
Well, it's an urgent matter, and one that the citizens of the county should be concerned with. Should also be concerned maybe with school busing at the moment too, but I mean, these are all things outside of our scope at the very moment, so I'm just not sure how to broach that.
I think that the warden is keen. I would suggest that it may not be, the urgency may not be there. It is intriguing, certainly, and I think that a balanced approach, whether from this entity or through the lower tiers, would be indicated in this instance.
So respectfully, if I could suggest, I would think it falls a little bit under our strat plan about health of our community. And then secondly, it would consider an education to us to take back to our respective communities about how Pembroke and Laurentian Valley managed to get their program in place, and then how what the town of Petawawa has done. I think if we look at it as an education, and then maybe there's a role for adjoining municipalities to talk about either joining those or starting their own. So I think it, if we considered education as opposed to us taking on a service, we might be more comfortable.
Okay, so if this was viewed as simply providing information in a very accessible format with all of the lower tiers available in the room, I think that's how I would frame the warden's comments. From my perspective, and certainly we have councillors here from Pembroke, I know with respect to the Sunshine Coach in Renfrew, we are largely hands-off. This is a non-profit entity that we are providing funding for. There are several municipal partners, Councillor Weirs being one of them. I believe, Councillor Nicholson, you are another. The town of Renfrew, Admaston and Brumley as well. Perhaps BV does as well. So through the provision of a fairly small amount of seed funding from each of the municipalities, it's leveraging a substantial investment through the transit funding. I'm presuming that the handy bus is similar. What Councillor Nicholson is describing out of Petawawa sounds substantively different from that, if this is a service that's being essentially put in place by the municipal corporation. That's where I would have a particular interest. Mr. Kelly.
Thank you, Chair. From our research, or from what we know, is the CCACs, or the Community Care Access Centres, have been largely engaged in transport, either through Care4 or through the Handy Bus or Sunshine Coach. And we could invite a member from the CCAC to this committee to present, and maybe that's the best path forward. And that would just be simple direction to staff without a motion. That'd be fine.
I certainly would be satisfied with that as a starting point. I think that perhaps, predicated on Councillor Nicholson's suggestion, whether it be the mayor of Petawawa, whether it be the CAO of Petawawa, there might be some value in having a direct representation, because that's the component, at least what I'm hearing, that is substantially different from the two services outside of the service that Care4 now does provide, but certainly the Handy Bus and Sunshine Coach, a municipal ownership, if you will, is substantively different from the models that are currently in place. Okay, so that direction has been given to staff. Any further new business? I see none. There was no requirement for a closed meeting at the time of distribution of the agenda. Does that continue to remain true?
It is still true.
Thank you. The date of the next meeting shall be Wednesday, October 16th. I would seek a motion to adjourn, please. Councillor Lafreniere, Warden Emo, all in favor? That is carried. We are adjourned. Thank you so much, committee.